All right, welcome back, everyone. We're going to continue down the other pediatric emergencies with the second lecture in this series. So, hematologic, oncologic, and immunologic emergencies are, I wouldn't say common in pediatrics, but are not uncommon in pediatrics. These patients may present with immunosuppression, and this can be due to congenital diseases of the immune system, chemotherapy, or chronic steroid use. These patients may present with severe illnesses or even shock, and special considerations for these patients include an acute awareness for things like sepsis, acute chest syndrome during sickle cell crisis, stroke with sickle cell crisis, tumor lysis syndrome, and then they have an increased overall risk of infection. You should be rapidly assessing these patients for signs of sepsis and decompensation. We've talked about decompensation of the pediatric patient a lot at this point, and we should be well aware that these patients decompensate rapidly, and once they decompensate, they become very, very difficult to treat, manage, and get back into a normal perfusion state. Examination should include long circulatory and neurologic exam, as well as evaluation of the joints and extremities for swelling or edema in those areas. Because some patients will have indwelling catheters, you want to evaluate the catheter site for erythema, redness, swelling, and tenderness. This can be a sign of central line infections and an underlying cause of septicemia. Von Willebrand disease is a bleeding disorder in which the patient is missing the von Willebrand factor, which is a protein that's essential for platelet adhesion that prevents blood clotting. Most people with this disease are undiagnosed. It ranges from mild forms such as nosebleeds to severe uncontrolled bleeding tendencies. Treatment for these patients is in the prehospital world is controlling bleeding and then transporting to a facility with hematology services. Leukemias and lymphomas, there are two forms of leukemia. They're broken down into acute lymphoblastic leukemia and acute myelogenous leukemia. At its onset, a child with leukemia often displays very, very few symptoms, and the condition may be diagnosed when a child has had a minor infection, such as a cold, but continues to be listless, febrile, pale with a poor appetite. Patients usually seek medical attention after weight loss or bruising without an unknown cause, or just these progressive delayed signs of infection. Treatment is going to involve long-term IV chemotherapy treatment, radiation therapy, and these patients may require supportive care and pain management if within your scope en route to the facility. Fever is a common pediatric complaint. Symptoms, it's usually a symptom of an infectious or an inflammatory process and can have loads of underlying causes. The general impression and primary survey will help you determine the severity. We should record temperature, things that we should be vigilant for in the pediatric patient with a fever, things like respiratory distress, hypovolemia, and then seizures. Petechial or purpuric rashes in the fever patient may indicate meningitis. We should be aware of that. And then a bulging fontanelle in an infant can be an indication of things like increased intracranial pressure. History taking and secondary assessment will help you determine these underlying causes and the severity. Perform on scene if the child is stable, but you may need to perform en route with a historian transported with you if the patient is seriously ill. They may not require any intervention for a fever patient, but you may need to administer antipyretics, fluid boluses, and anti-seizure medications depending on the patient presentation and your certification level. SIDS is sudden infant death or sudden unexpected infant death syndrome. It's the death of an infant younger than 1 that occurs unexpectedly, the cause of which is not immediately obvious before investigation. Most sudden unexplained infant deaths are either SIDS, which is syndrome, an unknown cause, or an accidental suffocation in the bed. This is usually because there are too many things in the bed with infant as they're sleeping, or they're inappropriately positioned and then ultimately asphyxiate during sleep. Be alert for other potential causes of death. Decision to start or stop resuscitative efforts on these children can be difficult. It is not an appropriate intervention. There used to be a common practice in EMS called show coding, and this is not an appropriate way to treat these patients. If following your protocols, your guidelines, your online med control, you should treat the patients based on presentation and underlying conditions. We don't go through resuscitative efforts just to go through the motion. That's not appropriate. It's not ethical, and is not helping anybody. Thorough size up in history are going to be important here. There are a couple of things to keep in mind for SIDS. They can often be precursed or indicated by things called ALTs or BRUIs. These are brief, resolved, unexplained events. And these are episodes where the infant becomes either pale or cyanotic, or has an apneic spell, particularly while feeding or just in general sort of care of the patient, and they may lose muscle tone. It can The problem with these brief, resolved, unexplained events is they can be completely anomalous and benign, but they also can be a precursor or an indication of an underlying issue that may lead to something like a SIDS event. So if you're called out, don't dismiss the caregivers, the family, if they tell you that, a patient, the patient they were completely flaccid and weren't moving while we were feeding. And then by the time you get there, the child's acting normally. This should carry a very high index of suspicion, and these patients need to be transported to a facility for further evaluation and further monitoring because of its potential correlation with events like SIDS later down the road.